Good afternoon, everybody. I'm just seeing the attendees coming in now at this stage, so I'll just give it a couple of minutes before we commence this afternoon's webinar. Thanks very much. Good afternoon, all. You're very welcome. And just give it one more minute and we'll get going now. Thank you. Okay, I think we're ready to go this afternoon, folks. Good afternoon, everybody, and you're very welcome to this webinar on the Assisted Decision-Making Capacity Act 2015 and the Mental Health Act 2001 and its implications for practice. This webinar has been organised by the Mental Health Operations Team in collaboration with the HSE National Office for Human Rights and Equality Policy. As you may be aware, Mental Health Operations have established an Assisted Decision-Making Working Group in preparation for the commencement of the 2015 Act. Today's event is one of a number of initiatives to raise awareness of the Act in mental health services and provide practical guidance to staff on the implications for practice. We recognise this Act will have significant implications across mental health services and that there remains degrees of unknown unknowns at this stage, just as there was for us back at the commencement of the 2001 Act in 2006. We also acknowledge that the early stages of commencement may raise more questions than provide clarity. We hope that providing a forum to tease out some of these issues will be of value to frontline practitioners. The proposed commencement of the Act will not happen on 21st of November as previously understood. This is because the required amending legislation has not progressed through the Seanad according to the intended timeline. We understand that it is hoped that the bill will have completed the legislative process by the end of 2022, with commencement of the Act in early 2023, and we'll obviously be providing more information as that emerges. The objectives of this afternoon's webinar is to stimulate discussion about the practical implementation of the 2015 Act and its intersections with the Mental Health Act 2001, to provide guidance to services and practitioners, and also to provide an opportunity for you to ask questions on the implications of the Act for your practice. And many thanks to those who have already submitted questions thus far. Today's webinar is primarily aimed at staff working in mental health services, but we are obviously aware that there are staff from other sectors and care groups who have joined us and who are most welcome. It is pitched at staff who have some familiarity with the 2015 Act and who have already accessed introductory materials on assistedDecisionmaking.ie in advance of the event. Obviously, as you'll be aware, this will be an iterative process as we will learn as further issues emerge over the coming weeks and months for the introduction of the legislation. Before I introduce our first speaker, I'd like to draw your attention to some housekeeping items. Firstly, the duration of this afternoon's webinar will be around 75 minutes. We will hear from 4 speakers, and the remainder of the session will address questions you have already submitted to panelists. We've received and are thankful for a wealth of questions in advance of today's event. We will try to address as many questions as possible. However, we will compile a frequently asked questions document after the webinar, which will deal with any unanswered questions. You may also wish to post a question using the question function, which the panel will endeavour to answer during the event. All information posted in the question function will be made available after the event in a PDF document. This webinar is being recorded and will be uploaded after the event to the Mental Health Hub on HSE land and on assistedDecisionMaking.ie. Details will be circulated after the event. A sign language version of the recording will also be available at that stage. CPD points are also available for today's webinar from the NMBI and the RCPI. Certificates will be issued to attendees after the event. If you're looking for CDP from the RCPI, please contact Aisling Duffy. Her email address will be added in the chat box. So now on to the speakers who have kindly agreed to participate today. We're joined today by a panel of experts, speakers who have been working since the 2015 Act was passed to provide greater clarity on what the Act does and does not mean for practice. We're also joined by Orla Keane from the Mental Health Commission, and she's very welcome today as well. So first up, I'd like to introduce Professor Mary Donnelly from the School of Law and University College Cork. She researches in the fields of mental capacity, mental health and health law. She was a member of the expert group to review the Mental Health Act in 2001, in 2013 and 2015, and is a member of the Mental Health Commission Legislation Committee. She was chair of the Technical Expert Group to develop codes of practice under the Assisted Decision-Making Capacity Act 2015. She is also co-chair of the HSE Assisted Decision-Making Implementation Steering Group and co-chair of the HSE National Consent Policy Steering Group. Over to you now, Mary.
So I'm going to talk about the interaction between the Assisted Decision-Making Capacity Act and the Mental Health Act of 2001. I think, as we all know by now, the Assisted Decision-Making Capacity Act constitutes a significant change in how we approach people who have decision-making or capacity difficulties. We're moving from, as my apple there on the side of your screen shows, a very neat line which divides the world between people who have capacity and who don't have capacity and making decisions on that basis, to a much more nuanced approach to people who have difficulties making decisions, which of course includes people who have mental illnesses or mental health difficulties. So among the things that we are going to see is an end to wardship, provision for decision-making supports, and we'll be talking more about these later. They are specifically decision-making assistants and co-decision makers. Provision for the appointment of a decision-making representative by the Circuit Court. We're also going to see a legal obligation on healthcare providers and others to facilitate a person in achieving capacity so that they can make decisions for themselves. We're going to see a prioritization of the person's will and preferences, notwithstanding that they have been found to lack capacity. And finally, we're going to see provision for advanced healthcare decision-making. So we are moving to a more complex, but also in many ways more human rights friendly and more nuanced approach to decision-making. So I suppose the first point to make is that the Assisted Decision-Making Capacity Act is applicable in mental health settings, all mental health settings, unless it has been specifically disapplied. So the two schemes are, as you'll see there in the picture, are sewn together to that extent, unless there has been a specific disapplication. However, for the vast majority of people in approved centres or with mental health problems in the community, the Assisted Decision-Making Capacity Act applies in its entirety. I want to talk a little about the disapplication of the Assisted Decision-Making Capacity Act. And I'm going to talk about this in two stages. I'm going to talk first about the disapplications which we have in the Act itself, the Act as it was signed off back in 2015. But then I'm also going to be talking about some significant changes which are coming through in the amending legislation. So I'll begin by talking about the Act itself. This disapplies itself, or says that it does not apply, or that it applies differently, I should say, in two situations where a person has been admitted under the Mental Health Act. In other words, where they're an involuntary patient under the Mental Health Act. The first is that the Act states, where a person has been admitted under the Mental Health Act, nothing in the Assisted Decision-Making Capacity Act authorizes a person to give the person treatment for a mental disorder or to consent to a person being treated for a mental disorder. The other disapplication relates to advanced healthcare directives. And this, in part 8, we have a long part which sets out many details on how advanced healthcare directives will work, but which includes in the 2015 Act an exception to the validity or the operation of advanced healthcare directives where a person has been admitted under the Mental Health Act. And it says that there is no requirement to comply with an advanced healthcare directive on treatment for a mental disorder where a person has been admitted under the Mental Health Act or is subject to conditional discharge under Section 13A of the Criminal Law Insanity Act 2006. The Act is very clear that this applies only in respect of treatment for a mental disorder, and that it does not apply, and this is clearly stated, to treatment for physical illness, which is not related to the amelioration of the mental disorder. So that's what the 2015 Act says. However, things have been moving along at quite a pace. And we've got some changes that we need to think about. So the Assisted Decision-Making Capacity Amendment Bill was published in, I think it was June of this year, and it will come into force alongside the 2015 Act. In other words, the two will come into force together. It's not yet completed its time in the Oireachtas, although we expect that to happen very soon. But for our purposes today, there are a couple of potentially quite significant changes in relation to the interaction between the 2015 Act, the Assisted Decision-Making Act, and the Mental Health Act of 2001. And I suppose the big point, or the first take-home point, is that the proposals in the bill, and I should say these are government proposals and have been accepted, so these are going to be part of the law, but as yet the bill has not been completed. One of the things we're going to see is that the significance of the basis for admission under the Mental Health Act is going to become very significant indeed. So the basis for admission is set out in Section 3 of the Mental Health Act of 2001. And this sets out two possible grounds on which a person can be admitted under the Act. The first of these, which is sometimes called the risk ground, and that's set out in Section 3(1)(a), states that because of illness, disability, or dementia, there is a serious likelihood of the person concerned causing immediate and serious harm to himself or herself or to other persons. The second ground, which is sometimes called the illness ground, sometimes called the therapeutic ground, says that because of illness, disability, or dementia, the judgment of the person is so impaired that failure to admit the person will be likely to lead to a deterioration, a serious deterioration in their condition, or would prevent the administration of appropriate treatment, and the reception, detention, and treatment would be likely to benefit or alleviate the condition of that person to a material extent. And that's Section 3(1)(b). And you'll note that treatment element is not stated in 3.1a. So it's a very different basis for admission. Now, up until this point, it didn't matter legally what basis a person was admitted under, or indeed if they were admitted, as is possible, under both parts of 3.1, both under A and B. However, the legislation, the bill which is going through, will make it become very significant, the basis on which a person is admitted, which section they're admitted, or which part or section of 3.1 they're admitted under. For admissions under section 3.1b, it is proposed that a decision-making representative will be now entitled to consent to treatment on behalf of a person who's been admitted under the Mental Health Act and who lacks capacity. So that is a substantial change. The other change is that where a person who is admitted under section 3.1b of the Mental Health Act has made an advance directive relevant to their treatment, to their mental health care, that advance healthcare directive must be complied with in the normal way, so it becomes legally applicable. There are no equivalent measures for admissions under section 3.1a, so only section 3.1b do these changes apply to. The final interaction point that I wanted to draw to your attention relates to detention. And as you know, one of the things which will be happening when the Act commences, the 2015 Act commences, is that new admissions to wardship will end, but will no longer be possible to admit someone to wardship. Now, under sections 107 and 108 of the 2015 Act, there's a requirement that people who are wards prior to commencement must have their deprivation of liberty, their detention, reviewed as soon as possible. And that review is carried out by the High Court. If the High Court is satisfied the person is suffering from a mental disorder, it may order ongoing detention for a period not exceeding 3 months. And it can then review and order further periods of ongoing detention of up to 6 months at a time. If the High Court finds that the person is no longer suffering from a mental disorder, it has no choice, it must order the discharge of the person. I should note, however, here that it is possible to make an application to the High Court under the High Court's inherent jurisdiction, and that might provide a basis for a person to be detained, notwithstanding that they do not have a mental disorder. And I suppose the final point to note here is, again, from a practice perspective, the review requires the High Court to hear evidence both from the consultant psychiatrist responsible for the patient's care and from an independent consultant psychiatrist which will be selected by the High Court from a panel which must be established by the court. So thank you for your time.
Thanks very much, Mary, for that. I think we'll all agree that was very useful information in terms of the legal framework and what changes will be in store. Lots of food for thought at this stage. Next up is Professor Brendan Kelly, who is a consultant psychiatrist at Tallaght University Hospital and Professor of Psychiatry at Trinity College. Brendan has been a member of the HSE Assisted Decision Making Implementation Steering Group and the Multidisciplinary Working Group on Advanced Healthcare Directives since 2016. He's authored and co-authored numerous peer-reviewed and non-peer-reviewed papers, as well as various books, chapters and books. His particular research interests include the epidemiology of psychosis, mental health services, the history of psychiatry, and human rights and mental health. Thanks, Brendan.
I'm going to talk about the capacity legislation and the Mental Health Act 2001, picking up on some of the points from Professor Donnelly, but also looking at how this will present clinically in mental health services. The first point I really want to emphasize is that this is all about capacity. It's about recognizing the presumption of capacity among all people who attend our services, and for those whose capacity might be called into question, putting in place everything we can to increase their capacity to allow them to make their own decisions. So the first big point here from a clinical perspective is that the 2015 Act underlines the already existing presumption of capacity for everybody attending services, including, of course, mental health services. If there is a reason to question somebody's capacity, then a functional assessment is required. In other words, figuring out if the person is able or unable to understand relevant information, retain it to make a choice, weigh that information up, and communicate a decision. But the emphasis really in this is about the presumption of capacity and helping people to make their own decisions whenever possible and with whatever support needed. It is useful for staff in mental health services to be very familiar with the levels of decision-making support that are outlined in the 2015 Act. These include a decision-making assistant, just someone to help with information and talking and thinking things through to help the person make their own decision, or a co-decision maker, which is when a person themselves can appoint someone to jointly make a decision, to give them that little bit more support. There is a process for this, and the person can arrange this themselves. Alternatively, a co-decision maker can happen through the circuit court, which following a hearing can request that a person put in place a co-decision maker to assist with joint decision making. And following a circuit court hearing as well, the court can either make a decision itself or recommend a decision making representative. The important thing from our point of view in clinical services is all of these people, if they are appointed, they must act in accordance with the will and preferences of the person, even if the person lacks capacity. So, for example, if I felt I was losing capacity, for example, for decisions relating to mental health care, and if I appointed a co-decision maker to jointly make these mental health care decisions with me, that co-decision maker needs to act in accordance with my will and preferences as best as they can figure them out at all times, even if I lack capacity to make decisions myself. The reason it's so important, and I'm emphasizing that this person must act in accordance with the will and preferences, it means that if an outpatient or a voluntary inpatient in our mental health services has one of these decision-making supporters, then a decision about treatment that is made with this supporter is the same as a decision they might have made themselves without such support if the person had capacity to do so. So this applies to an outpatient or a voluntary inpatient who has one of these decision supporters in place. A decision that results from that is the same as a decision the person would have made themselves if they had the capacity to do so. I'll give an example. If an outpatient or a voluntary inpatient is taking medication on the basis of consent provided with such support, but if the person then stops accepting the medication, they cannot be compelled to take it unless they meet the criteria for involuntary admission and are so admitted and deemed to lack capacity. None of these three levels of decision-making support authorize coercion, in other words. If the person stops taking the treatment, they cannot be compelled to do so unless they are involuntarily admitted. And I think that is one of the second big message from me, is that the 2015 Act facilitates the treatment of compliant, incapacitated people, but it does not authorize coercion as the legislation presently stands. As a result, the 2015 Act, the capacity legislation, is not a substitute for the Mental Health Act in any situation. One act does not trump the other. These acts do different things. The capacity legislation is about presuming capacity, if necessary, doing a functional assessment and providing levels of support for decision making. Decisions can be made with that support, but that support for decision making does not authorize coercion. The Mental Health Act 2001, on the other hand, can be used in certain circumstances for treatment without consent and, if necessary, against the will of the person, subject to the criteria in the Mental Health Act. Looking at involuntary patients now, under the Mental Health Act, if somebody is an involuntary patient under the Act, the consent of the patient is required for treatment for an involuntary patient, except where the consultant psychiatrist feels the treatment is necessary to safeguard the life and health of the patient or alleviate the condition, relieve suffering, and by reason of mental disorder, the patient concerned is incapable of giving such consent. So with regard to involuntary inpatients under the Mental Health Act, it is already the case that the consent of the patient is needed for treatment, unless the patient is incapable of providing such consent. How does the capacity legislation interact with this? Well, if an involuntary patient lacks capacity for treatment decisions, and they do not have a decision-making assistant, a co-decision maker, or a representative in place, the treating team can consider assisting the person to get these supports. The supports of the capacity legislation are available to involuntary patients, as well as voluntary patients and outpatients. Otherwise, that is, if the involuntary patient does not have these things in place, and maybe a process will start to put them in place, maybe not, but otherwise, and in the meantime, treatment can be provided on an involuntary basis as outlined in the Mental Health Act in the normal fashion. So for the involuntary patient, the first step is they might have capacity to make treatment decisions. If they don't, then treatment can happen under the Mental Health Act. And if they don't have decision-making supports in place to optimize their decision-making capacity, those can be commenced, but treatment can also be commenced under the Mental Health Act. So involuntary patients can access decision support services, and nothing in the 2015 Act can or should delay essential care. Care can still be provided. Finally, advanced healthcare directives. And this is a summary. Advanced healthcare directives apply to all persons in mental health services, outpatients, voluntary inpatients, and involuntary inpatients in the same way as everybody else, with just one exception. So we know that advanced healthcare directives in the general scheme of the legislation allow a person to specify a treatment that they do not want under given circumstances, should those circumstances occur and the person lack capacity at the time. And advanced healthcare directives also allow a person to request a specific treatment in specific circumstances, should those circumstances occur and the person lacks capacity at the time. A refusal of treatment is binding, but a request for specific treatment must be taken into account. That is the generality. Broadly speaking, that also applies to all people in mental health services, with just one exception. And Professor Donnelly did mention this. If a person is involuntarily admitted under Section 3.1a, that is the risk criterion, their advanced healthcare directive pertaining to mental health care only is not valid for the duration of that involuntary treatment. So broadly speaking, advanced healthcare directives apply in mental health services in the same way. The only exception is an involuntary patient under the risk criterion. Their advanced directive pertaining to mental health care is not valid for the duration of that involuntary treatment. So to summarize, for mental health services, there is, and indeed generally, the 2015 Act brings a presumption of capacity, and there must be a very strong reason to question that capacity. So it is not anticipated that there will be lots of capacity assessments happening all around the place. The presumption of capacity is very strong. The Act provides for 3 levels of decision-making supporters as indicated: the decision-making assistant, a co-decision maker to jointly make decisions, and then a decision-making representative. These supporters must always act in accordance with the will and preferences of the person, even if the person lacks capacity. Therefore, the 2015 legislation facilitates treatment of compliant, incapacitated people, but it does not authorize coercion, and it is not a substitute for the Mental Health Act. One act does not trump the other, they do different things. So I suppose to finish up, the emphasis on this legislation is about capacity, presuming it, supporting it, and helping people make their own decisions. It's not a substitute for the Mental Health Act. As matters stand, it does not authorize coercion or treatment against a person's will, as the Mental Health Act does. Thank you very much.
Many thanks, Brendan, for your presentation. I think we all agree we have some level of uncertainty as we head towards the implementation of the Act, and certainly hopefully this and the other presentations are addressing some of the questions that people have on the ground. I'd like to now hand over to Miss Anya Flynn, and Anya is the Director of the Decision Support Service. She's a solicitor and was a senior partner in Dublin firm KOD Lyons, specialising in public interest law. She was on the panel of legal representatives of the Mental Health Commission and the Mental Health Criminal Law Review Board from their inception in 2006, and represented wards of court instructed by the General Solicitor. Anya has written and lectured on human rights and has been a member of the Human Rights Committee of the Law Society since 2012. Prior to her present appointment, she was a member of the Law Society's Mental Health and Decision Making Capacity Task Force. Thanks, Anya.
Thanks very much. So up to this point, you've been hearing about what you can expect in terms of your interactions with the Assisted Decision-Making Capacity Act. And in my 10 minutes, I want to focus on what you can expect specifically in terms of your interactions with the DSS. So the Decision Support Service is located within the Mental Health Commission, and this audience will be very familiar with what the Mental Health Commission does. I find the easiest way to describe the DSS's relationship with the Mental Health Commission is to quote from the Act itself, so that the director of the DSS is appointed by the Mental Health Commission to carry out the functions conferred on the director by the 2015 Act. So we take our functions from that Act, and our colleagues in the Mental Health Commission have their functions under the Mental Health Act. The regulatory function, inspections, and the running of the mental health tribunals. None of those Mental Health Act functions are changed by the Assisted Decision-Making Capacity Act. So the way that you have engaged with the Mental Health Commission up to now is the way that you continue to engage with the Mental Health Commission in the delivery of its functions. As you know and will have been hearing, the Mental Health Act itself is to undergo amendment, so do keep an eye on that process. The functions of the Decision Support Service then include the following. So thinking first of all about our outward facing functions and our engagement with the public. We have a duty to promote awareness and confidence in the 2015 Act, to provide information to relevant persons and decision supporters. So that would be information about how to conduct themselves under the Act, and we're talking to relevant persons then about the options that are available to them under the new support framework. As part of our communications functions, we have a website, and that has been up and running for more than 2 years at this stage, and on it you will find plenty of information about the 2015 Act itself and our own functions. Then, in terms of how we might engage with stakeholders such as yourselves, we have a duty to provide information and guidance to bodies on their interactions with relevant persons and with decision supporters. We're authorised to recommend organisational change to promote the exercise of capacity. As you will know, we maintain registers and will be supervising the decision support arrangements under the Act. So we have that regulatory function. We have a duty to investigate complaints, and those are complaints about decision supporters and decision support arrangements. I'll say a little bit more about that in a moment. We maintain panels of persons to carry out certain roles under the Act. We have codes of practice, and you'll be aware that we conducted a public consultation in relation to a number of draft codes, including codes for healthcare professionals late last year into early this year. We have a specific function in relation to this international instrument, the Hague Convention on the International Protection of Adults. So that appoints the Director of the Decision Support Service as the central authority, and that convention arises when there's a cross-border aspect to a person's affairs. And we have an overall duty to keep everything under review and to report and make recommendations to the ministers in relation to the operation of this Act, and we'll be welcoming feedback from stakeholders such as yourselves so that we can ensure that everything is kept fit for purpose. So thinking then about the new support framework, and I know you will have been hearing about this already and will have a good level of familiarity. So let's think about the DSS's roles in relation to these various tiers of support and how you might expect to engage with us. At the lowest tier, and I won't go into the specifics of the functions of a decision-making assistant, but in broadest terms then the DMA exists to help the person obtain information and to help them to explain what they want to do and to ensure that that decision is carried out. Overall, you will have been hearing that these tiers of support are available within the mental health setting, subject to very limited exceptions, which I know will have been explained to you. At this tier of support, then, the decision-making assistant isn't making the decision at any level. The appointer is still making the decision. There's no capacity assessment required. And where the DSS steps in then is that this decision-making assistance agreement is notified to us so we can verify that a person really is a decision-making assistant. It isn't formally registered in the same way that applies with some of the other tiers of support. But if you want to know if somebody really is a DMA, you can find out from ourselves to ensure that they're acting within scope. As you will know then, at the middle tier, there's quite a bit more involved. So co-decision making describes a relationship of joint decision making. And this is an agreement which is formally registered with the Decision Support Service and kept on our searchable register. It comes to us with a number of pieces of supporting documentation, including a capacity statement from a medical or other healthcare professional. The co-decision making agreement is then supervised by the DSS, so we ensure that everything is going well, and we specifically have to keep the capacity component under periodic review. So if as a mental health professional you have been involved in supplying the initial capacity statement to support the registration of the co-decision making agreement, we may be coming back to you, engaging with you around the person's capacity. And again, as I say, this is held on a searchable register, so if you ever need to know whether somebody properly is a co-decision maker, it's something that you can check with us. And as you will know then, at the top tier of support is the court appointment of a decision-making representative. And that might be an outcome of an application under Part 5. That's an application to the court by any person with a bona fide interest in the welfare of the relevant person, or it may be an outcome of Part 6, and that's the review of those current adult wards of court. There are 2,200 approximately adult wards of court, some of them in residential mental health services, and all of them will be coming out of wardship. The Decision Support Service isn't directly involved in that process, but if the wardship court directs it there to move over to one of the forms of support supervised by the DSS, then we would be hearing about them at that point. So the court may appoint a decision-making representative. They may appoint, where necessary, from the panel of decision-making representatives, which is maintained by the Decision Support Service. That's when there's nobody available, suitable or willing in the person's life. And any DMR always takes their authority from the court order, and the court order is sent to us for registration. So again, that's something which you as mental health professionals may want to check. If you're engaging with somebody who is presenting as a DMR, then again, it can be verified with us by searching our register. And we supervise the performance of the decision-making representative as they deliver on their duties under that court order. The other arrangement I want to mention to you is the Advanced Healthcare Directive, which obviously is the tool for advanced planning, and I know you will have been hearing about where they apply or don't in the mental health setting. But thinking just about how the DSS engages around advanced healthcare directives, we have a bit less to do. So under Part 8 of the Act, the Minister may make regulations to require us to establish a register of advanced healthcare directives. May meaning that it's not mandated under the Act, and those regulations have in fact not been written at this time. So as of commencement, we won't have a register of advanced healthcare directives, and that may change. We understand that the department is willing to provide for those in time. An advanced healthcare directive, however, doesn't have to be registered in order to be valid. So it's distinct from some of the other arrangements under the Act. An advanced healthcare directive is valid without being put on a register, and that's important. We will have that broad information function to provide information to persons who want to make an advanced healthcare directive, and that information is on our website. And the DSS can investigate complaints about a designated healthcare representative who is appointed in an advanced healthcare directive. So just staying for a moment then with our complaints function, I won't go through all of these grounds of complaint, but in broad terms, we are authorised to hear and investigate complaints in relation to decision supporters and decision support arrangements. We don't take complaints about professionals or services. Our role is limited to the framework supports under the Act. So that if somebody is acting outside of what the Act authorises them to do, or is not performing their functions as provided for in their specific decision support arrangement, then they could be in breach. And it's something which needs to come to us to investigate to ensure the integrity of these arrangements. And we have a range of powers in so doing, so that we can commission a special or general visitor. They are panel members who assist us in the delivery of these functions by taking up information and reporting back to us. With the amendment bill, which is making its way through, we will be able to apply to court temporarily to suspend a decision supporter from acting. And ultimately, as an outcome of one of these investigations, we may apply to court to have them removed from their role on a permanent basis. We can also resolve complaints informally. We may need to investigate for criminal investigation, or alert the appropriate authorities of a safeguarding matter where that arises. So I think from your own perspective, important to know that it may be somebody in mental health services who becomes aware that one of these arrangements isn't working well and will therefore escalate to ourselves. And in turn, we may need to take up information from a service provider in the furtherance of that investigation. Briefly then on the codes of practice. Codes of practice were drafted by a ministerially appointed working group led by the HSE. So they came to us in very good shape. And there are codes of practice for healthcare professionals then, and a code in relation in particular to working within advanced healthcare directives. Those codes will be published with ministerial approval shortly, and the status of any code is that a person concerned shall have regard to a code of practice when performing any function under the Act in respect of which the code provides guidance. A breach of a code is not something that gives rise to civil or criminal liability, but it is something that may be taken into consideration in other proceedings. And within the code for healthcare professionals, you will see chapters which I hope are useful to you concerning healthcare professionals' interactions with decision supporters and with ourselves, the decision support service. And also linking from the codes, you will find vignettes setting out anticipated real life situations. So I hope that they will be useful also. I think it's important to say what the DSS doesn't do. So we don't make decisions for people. We don't directly appoint decision supporters. We don't provide legal advice. We provide information and guidance. Where you go to for legal advice is still where you go to for legal advice. And we don't, as I've said already, have a function to regulate or become involved in any way in complaints about professionals or services. And finally then, these are just some things which I think might be appropriate for this sector to consider in preparation for commencement. So where you encounter queries about the support framework, it's appropriate to direct those to the decision support service, to our information service. We take queries already, in fact. As I say, we don't supply legal advice, but we do supply information about what is available under the Act, and we welcome those queries. Some of you, as I say, may be dealing with persons who are wards of court. So anticipating the discharge of those adult wards from wardship, and all of them will be aware that they may be transitioning over to the new framework supports supervised by ourselves, the Decision Support Service. And I think you'll be getting used to the idea of interacting with decision supporters and understanding their remit, both their remit under the Act, including their obligations to apply the guiding principles, and their remit in terms of the specific decision support arrangements in which they are involved in individual cases. You will be getting used to the idea, I think, of accessing our registers, obtaining copies of decision support agreements and orders when necessary, and we will hold registers then of the co-decision making agreements, decision making representation orders from the court, enduring powers of attorney, but be aware of changes coming with the amendments to the Act, which will mean that an EPA can't cover treatment decisions. And those decision making assistance agreements at the lowest tier, if you remember, whilst not registered with us, may be verified with us, we can confirm that somebody really is a DMA. Be aware that arrangements may be varied or revoked over time. They are not permanent necessarily, and they may be subject to red flags, for example, where a complaint has been raised with us. So I think it's for the sector to consider what is best practice in terms of accessing the register. And then, as I've said, where things go awry, it may be that it's somebody within a service who comes to us with a complaint, or it may be that when a complaint has come to us, that if it concerns decision making in relation to mental health decisions and treatment, we may be going to you to find out what has been happening in the context of a decision support arrangement. So that is where I will leave it. As I say, our website has been up for some time, and there you will find lots more information and frequently asked questions, which I hope are helpful to you. Thank you.
Many thanks, Anya. Greatly appreciated. A lot of information there on the decision support service and the different roles within the service, and what it will be doing, and as well, importantly, what it won't be doing and what it isn't. Next, I'd like to hand you over to Bear Grogan. Bear has worked with and advocated for people with mental health difficulties for many years. Bear joined Mental Health Reform in August 2021 as the Policy and Advocacy Coordinator. In February, she was promoted to Policy and Research Manager. Before Mental Health Reform, she worked in the Dáil as a parliamentary assistant for over 7 years and 2 elections. So I'll hand over to Bear now. Thanks very much.
Hi, I'm Bear Grogan. I'm the Policy and Research Manager with Mental Health Reform. I'm delighted to be here today taking part in this webinar. Before I get started, I just wanted to give you a quick overview of who we are, in case you don't know about us. So we're Ireland's leading national coalition on mental health, and our vision is of an Ireland where everyone can access the support they need in their communities to achieve their best possible mental health. And we do this with our 80 member organisations. So we drive progressive reform of mental health services through coordination, policy development, research and innovation, and accountability and collective advocacy. And I'm sure most of you are aware of many of our member organisations, such as Pieta, Samaritans, Bernardo's, ISPCC, Focus Ireland, other addiction services, Traveller Mental Health. So we try to bring voices together around pieces of legislative reform, like the assisted decision making, and also the reform of the Mental Health Act. So the UN CRPD, again, I'm sure many of you have heard of it. It's the UN Convention on the Rights of Persons with Disabilities. And I'm mentioning this now because it's linked to mental health difficulties, enduring mental health difficulties, and that's also linked to capacity and assisted decision making. So the term psychosocial disability has been adopted by the UN, which includes people who have lived experience of mental health issues or who self-identify with the term. The CRPD has clearly stated that the protections and rights set out in the UN CRPD extend to these groups. So in our national mental health policy, sharing the vision, the terminology used is mental health difficulties, but it's just to reiterate that that is psychosocial disabilities, and therefore people with enduring mental health difficulties do have rights under the UN CRPD, including the right for legal capacity and decision making. So back this time last year, October 2021, we got a human rights analysis done on the draft heads of bill, which were produced to reform the Mental Health Act 2001. the Assisted Decision Making Act and the reform of the Mental Health Act are interlinked. And the human rights analysis speaks about the rights of people for assisted decision-making supports and the use of advanced healthcare directives. So that's what I wanted to talk to you really about today. And that the exclusion of people detained under the 2001 Mental Health Act would violate the UNCRPD because it would discriminate on people on the grounds of disability. And this is, it comes down to discrimination and psychosocial disability being seen as an area of discrimination. There's lots of research on the area, and I suppose today, in these couple of minutes and in the questions that we'll have afterwards, I really want you to think about how we can do things differently and the absolute culture shift and paradigm shift that's needed to put people at the heart of their decision making. And I think sometimes that can be really difficult when we're overworked and under-resourced and overstretched, and you know there's the waiting lists are growing, and we have a lot of different complex cases and people looking for support, but every single person is an individual and should be seen in that individual right, presumed to have capacity and trusted that their will and preferences are what they've wanted, and that they're making an informed decision about that either themselves or with supporters. So again, on our website on mentalhealthreform.ie, we have a lot more information about research and evidence bases. So the research does show that if you have an advanced healthcare directive for your mental health care, it can actually reduce involuntary admissions, promotes recovery, and be cost effective. And just to say, it's not only us as an NGO coalition saying this. The Mental Health Commission has also raised concerns about that the provisions and the rights under the Assisted Decision Making Act should be extended to people detained under the Mental Health Act. So there was a whole pre-legislative scrutiny process in February of this year. So the CEDIY committee is the Children, Equality, Disability, Integration and Youth, and the transcripts and videos of those processes and engagements are all on oireachtas.ie, in case you have nothing better to be doing. And want to do that reading and watch back politicians. So AHDs, the Advanced Healthcare Directives, are a critical support to enable people and empower people and support people in exercising their capacity. And again, we talk about recovery and working towards recovery, and all of the research will suggest that people developing advanced healthcare directives while they're well and while they have capacity benefits the person and their recovery. So an international review showed that they can reduce involuntary admissions by 23%. They're also associated with a reduced need for readmission. And we know in Ireland, their readmissions are around 60%. So it's really about, I'm here today to ask you to kind of switch your thinking, put yourself in the shoes of the person who maybe is coming into a service, who already knows maybe what medications work for them or don't work for them, the side effects, have worked with their supports and services to work on an advanced healthcare directive and their will and preferences. There's loads more information on this, so please sign up to our newsletter at mentalhealthreform.ie or get in touch with myself, B. Grogan at mentalhealthreform.ie. Very, very happy to have further discussions on this and looking forward to today. Thank you.
Many thanks, Bear. Greatly appreciated as well. Finally, but by no means least, I'd like to hand you over to Ms. Elaine McCockley. Elaine is a Senior Project Manager in the HSE National Office for Human Rights and Equality Policy. Elaine has extensive clinical experience as a speech and language therapist, where she gained first-hand experiences of the challenges faced by people who are disempowered within health and social care systems. Elaine holds an LLM in Healthcare Ethics and Law from the University of Manchester, where she volunteered as a dementia legal advice clinic. Elaine has a strong interest in ethics education and advocacy and continues to collaborate with people using services and teams within and outside the HSE. Thanks a lot, Elaine.
I'm going to take a few minutes to walk you through the wealth of resources the National Office for Human Rights and Equality Policy has developed for staff in health and social care settings, including mental health services, in preparation for commencement and implementation of the Assisted Decision Making Capacity Act. So this is our website, www.assisteddecisionmaking.ie, and you'll find links to all of our resources on this website. We hope they'll be used widely for training and education purposes. They're aimed at staff across all services, including mental health services, and are pitched at a variety of levels, from basic introductions to the Act to more detailed considerations of more complex scenarios. So you'll find a 9-minute explainer video and some up-to-date FAQs, a 20-minute short presentation on the Act. You can download the book on personal and professional reflections. You'll see all the issues of our newsletter and information on any upcoming events and of any other useful links to resources. This year, we used feedback from a staff survey to develop a webinar series to provide guidance to service and practitioners and to explore case studies within the framework of the 2015 Act. We convened panels of experts by experience, clinicians, advocates, collaborators from the Decision Support Service, the Office of the Wards of Court, HICWA, IREC, TILDA, and others to explore some complex case scenarios related to the topics you can see on the screen. How do I support someone to make a decision? How and when to engage with the Decision Support Service? Positive risk-taking and unwise decisions, functional assessment of capacity, and respecting the rights of the person and the role of families under the 2015 Act. All of these webinars are available to watch back on the website, but we appreciate that not everybody is going to have time to watch the full recordings. So if you look at the arrow below each YouTube link, you'll see a list of each of the case scenarios that are discussed by the panel. So you might like to identify any particularly relevant scenarios for your service or your team, and maybe use these to present at journal clubs or team meetings. All of our e-learning resources are available on HSE land, and this means they're available to anyone working in health and social care in Ireland, including staff from Section 38 and 39 agencies, students, GPs, practice nurses, temporary or agency staff, and volunteers. We're currently working on 3 modules for staff around the Assisted Decision Making Act, and these will be available on HSE land before commencement. The 3 modules are an introduction to the Act and guiding principles, guidance on working with decision supporters who are appointed under the Act, and guidance on advanced healthcare directives. We currently have a programme on HSE land on supporting decision making in health and social care, and we work closely with people using services, clinicians, including mental health teams, and advisors from services all over the country to develop these 3 modules. First module is about supporting a person to make their own decisions, how to presume capacity and use appropriate tools and strategies, and how to respect a person's will and preferences, even if they lack capacity to make a particular decision. This module includes a story about a character called Alan, whose social worker and community mental health team support him to make a decision about where he would like to live. Module 2 is about supporting a person to plan for the future, whether that's in a statement of wishes, an advanced healthcare directive, a think ahead form, or any other method. This module includes the story about how Alan is supported to plan ahead for when he might become acutely unwell in the future, and to record a statement of his wishes. The third module is an introduction to the functional assessment of capacity, particularly in relation to maximising a person's decision-making capacity through support, establishing if there is a valid trigger to assess a person's capacity, and an introduction to the functional approach. This module continues the story about our character Alan. The community mental health team identified there is a valid trigger to assess his decision-making capacity in relation to a treatment decision as he is acutely unwell. In July 2022, the National Office for Human Rights and Equality Policy published the revised National Consent Policy, which represents an extensive revision and rewriting of parts 1 and 2 of the 2013 Consent Policy. And the language in this revision in particular has an emphasis on the importance of will and preference of a person who may lack capacity. It has been changed into a line in preparation for commencement of the Act, and the policy will be updated following commencement. The revised National Consent Policy applies to all actions conducted by or on behalf of the HSE with people in all locations, and you can download it from our website. We developed an 8-minute video using the voices of people who have used services, talking about why consent is important. And this video is available to watch on our website, and we hope it will be used to raise awareness and for education and training. We also have 2 e-learning modules on HSE land to support the revised consent policy. Module 1 is on the general principles, which helps learners to ensure valid consent is sought for the person for every intervention, to ensure that they can provide relevant, accessible information, and to react appropriately if a person refuses consent. Module 1 explores issues around capacity to consent, including this story about a young woman who was admitted to a mental health service. Module 2 is on working with children and young people in the consent policy. So in summary, our website is the central repository for all our resources. You can use the shortcut hse.ie/national consent policy for resources relating to the consent policy. All of our e-learning modules are on HSE land, and I would also refer you to the Decision Support Service website as an excellent source of information. If you'd like to join our mailing list to receive our newsletter and other updates, please email adm@hse.ie. Thank you.
Many thanks, Elaine, for that. I think we'll all agree there's a huge amount of information available, along with practical examples for all the staff. It's hugely appreciated. And thanks to everybody for speaking so far. We'll move on now to the questions and answer session. Thank all the speakers, and invite them all to the panelists to turn on their videos. As I said, we're also joined on the panel for questions by Orla Keane from the Mental Health Commission. I see lots of questions have already been answered throughout the webinar, so thanks to all for submitting as we go along. So if okay, we'll move on to the questions, folks, if that's okay with everybody. And again, a lot of these have, some of them have already been touched on in probably the questions and answers in some of the presentations, but just to reinforce some of the points that have been made, and on the basis of some of the questions that you have all submitted in advance, which has been really appreciated, and I think is where we'll all sort of get a greater understanding of the forthcoming legislation. But my first question, I suppose, Brendan, is for you, if that's okay with you. And just to consider, what will happen where immediate decisions need to be made in practice?
When immediate decisions need to be made, those decisions can still be made. Nothing in the 2015 Act should or can delay treatment that is necessary in the immediate term. The HSE National Consent Policy addresses consent in emergency situations in section 2.5, and you can see the HSE National Consent Policy online, and it says, in some serious emergency situations, the degree of urgency of providing an intervention may be such that there is no time to provide the information to the person prior to intervention immediately necessary to save the life or prevent a serious detriment to the health of the person. And in these cases, the necessary intervention can be administered, provided appropriate steps are also taken to increase the person's capacity so that they can make their own decisions when that very, very acute emergency happens. So if immediate decisions need to be made, they can still be made, emergency treatment still provided, and nothing in the Act can or should delay or prevent immediate and necessary treatment.
Very good, Brendan. Thanks very much for that. And just a follow-up question then as well, how best to manage a situation where an adult with severe anorexia nervosa, or perhaps a psychosis and not eating, who has capacity to make decisions and has expressed a wish not to be hospitalized or NG fed. They may be admitted to hospital under the Mental Health Act as there is a risk to themselves. However, supportive meals are insufficient, and you want to take the least restrictive approach and consider their will and preferences. How would we approach that?
Right, so this is one of the most complex situations, and neither the 2015 Act nor the 2001 Act provide all the answers in this situation. I think they can each provide bits, but it's not a complete answer. So as the questioner correctly says, the Mental Health Act can be used for a mental health treatment when the various criteria are met. If the person lacks decision-making capacity in relation to various parts of this, then the supports of the 2015 Act can be brought into operation as outlined in the capacity legislation, but it doesn't completely solve the problem. And I know there are a lot of applications to the High Court. The inherent jurisdiction of the High Court will remain. Hopefully it will not need to be used as much. And I suppose the final thing here is, whenever we get around to revising the Mental Health Act, there is a revised definition of treatment proposed in the current heads of bill under the Mental Health Act, which suggests that treatment should include, among other things, the administration of physical, psychological, and other remedies relating to care and rehabilitation of the person under clinical supervision for ameliorating a mental disorder, and to include any relevant ancillary treatment or tests required to safeguard the life or ameliorate the condition. That's what's in the current heads of bill, which might or might not be part of the revision of the Mental Health Act, which might or might not happen in due course. But for the moment, the Mental Health Act will do its bit in those difficult circumstances. The Capacity Act may come into play. The inherent jurisdiction of the High Court may be relevant because the 2015 Act does not completely resolve that dilemma.
Very good. Thanks very much, Brendan. I'll just move on to Bear now, if that's okay with everybody. And Bear, just a question for you to start off. How can the Assisted Decision Making Act be useful in the context of supporting individuals with severe self-neglect in the context of severe and enduring mental illness?
Thanks so much, Kevin. So I suppose that the main thing is that the person will be able to appoint supported decision makers or decision making assistants. But sometimes it could be, you don't need to go down the formal route. You might have informal supports. You might have, circles of support around the person, peer support, advocacy, and rather than having to go down the formal decision making route. Depending on the person's needs. And this is why I suppose I focus so much on advanced healthcare directives in my presentation, and just to highlight them again here, because when the person is well, it's a really good time to have those conversations, to talk about their will and preferences, and to have the will and preferences in writing for those times where they might become unwell.
Thanks, Bear, very much. Mary, a question for you here. How will the Assisted Decision Making Act align with the proposed revision of the Mental Health Act? And will the Mental Health Amendment Act 2018 be commenced along with the Assisted Decision Making Act, resulting in the removal of best interests in the Mental Health Act 2001? That's a lot of numbers, a lot of acts.
It is. Thanks, Kevin. So I guess the hope and the plan is that the revisions to the Mental Health Act that the reformed Mental Health Act will bring it much more in line with the Assisted Decision Making Capacity Act, because the acts aren't really entirely knitted together as well as one might hope. So hopefully the reform to the Mental Health Act will address some of those issues. So the expectation is that they will be much more closely knitted together afterwards than is currently the case. I suppose, and just to bring to your attention, and this is something which we've just heard recently, is that the Mental Health Act revisions are being prioritised by the Department of Health. So hopefully it won't be too long before we start to see those starting to come to fruition. The second part of the question was about the 2018 Act, and that's the Mental Health Amendment Act of 2018, which, as we know, was passed in 2018 but hasn't yet commenced. Now, we know it's not going to commence before the Assisted Decision Making Capacity Act, and that 2018 Act, in a sense, brings the principles of the Mental Health Act in line with the principles of the Assisted Decision Making Capacity Act. We know it's not going to commence until the Assisted Decision Making Capacity Act is commenced, but we don't know at this point, and as far as I understand, there is no nice, neat answer on this, which confirms that it will commence at the same time as the Assisted Decision Making Capacity Act. So we have to wait and see. We do know it won't happen before it, but we don't know for sure that it will commence at the same time as the Assisted Decision Making Capacity Act. Thanks.
Thanks, Mary. Appreciate that. And just a follow-up question, and I'm just conscious of time as well, folks. There's a lot of questions to get through, so we'll try and conclude at 3:15. The mental health legislation, Mary, primarily supports people admitted to hospital involuntarily. How does the Assisted Decision Making Act protect people who are voluntarily in hospital, where there is a question of whether they have full capacity to consent to treatment, and if information about the pros and cons is not always fully understood?
Thanks very much, Kevin. And I suppose the big point to note is that the Assisted Decision Making Capacity Act and all the tools it offers apply entirely to voluntary patients who have capacity difficulties. So that includes the decision-making supporters, which I know everyone has spoken about a little bit, and Ber made the point there, they're talking about people with that when they're well can often be a very, very important point. But crucially too, the principles of the Assisted Decision Making Capacity Act, which includes recognizing will and preferences, acting for the benefit of and the person and in good faith, and all the other least restrictive, respecting rights, listening to the person's views, all of those apply entirely in the to voluntary patients in an approved centre. So the basic answer there is all of the Assisted Decision Making Capacity Act applies in its entirety to voluntary patients who have capacity problems in or capacity difficulties in an approved centre. Thanks, Kevin.
Excellent, Mary. Thanks very much. I'll now just point a few questions towards Anya, if that's okay. Anya, what are the main differences between a ward of court and a DMR in their roles in working to protect the rights and welfare of service users who are deemed to lack capacity, for example, due to advanced dementia?
Thanks very much, Kevin, and I'll try to be quick on this one. So when an application is made for wardship currently, the outcome is that if a person is made a ward of court, then they are a person of unsound mind, incapable of managing their affairs. The court effectively takes over decision making together with input from a committee for the estate or a committee for the person. So that's been described as very much a blunt instrument. When the court appoints a decision making representative, it's in relation to specific decision or decisions, and it is finite in time and scope. And the decision-making representative takes their authority very definitely from that order and subject to some restrictions spelled out in the Act. So it's narrower, it's kept under supervision, and it's capable, another question related to this, it's capable of review and re-entry. So it's in a sense a much more agile document, which is for fixed purpose, fixed duration.
Thanks, Anya. And again, just a follow-up question then. How and when should a staff member make an application for a decision-making representative?
Yeah, I think that refers to part 5 of the Act. Any person with a bona fide interest in the welfare of a relevant person may make an application to the court. It's going to be primarily the Circuit Court. It would be the High Court if this is a decision around life-sustaining treatment or living donor organ donation. So it's if there is a genuine concern about the person's capacity in relation to that specific decision, the court can then make a declaration as to whether the person has capacity in relation to that matter, and may actually either make the decision, the court can do that, or appoint a decision-making representative. So it would depend on when you are confronting a decision and where everything else has been tried. Remember, it's the least restrictive alternative that you need to be looking for. So it's when all else has failed and as a last resort, and the court will ask that question, that you would be bringing an application to court. So it must be very much, on that basis.
Okay, Elaine, thanks very much, Anya. That's great. Elaine, I'll come to you now with a couple of questions, if that's okay. Is there going to be documents or procedures drawn up, such as identifying and interfacing with formal decision supporters?
Yes, well, the Decision Support Service will be publishing the codes of practice, as Anya has mentioned. So that includes a code of practice for healthcare professionals, and that includes guidance on interacting with decision supporters. We will also have an e-learning module on HSE land on working with decision supporters appointed under the Act. And then there'll be some guidance on accessing or using the searchable register in the DSS.
Very good. And then another one for you. Would you have clarification regarding the assessment of capacity, please, and who should undertake them and based on what? Traditional functional assessment of capacity has been carried out by consultant psychiatrists. What additional training on functional assessments of capacity will be made available to other MDT members on the team other than virtual training already available?
Sure. So Brendan has already typed an answer on this, and that ideally the person assessing a person's capacity would be a person familiar with them and familiar with the decision. Under the 2015 Act, registered medical professionals and 6 classes of healthcare professionals are prescribed by regulations to conduct functional assessments in 2 instances, and that's to make or to vary a co-decision making agreement, or to create or vary or revoke an enduring power of attorney, or when the attorney wants to make an application to register that EPA. So the 6 other classes of healthcare professionals in the draft regulations are occupational therapists, psychologists, registered midwives, registered nurses, social workers, and speech and language therapists. And just in relation to the training, the DSS and HSE will produce an online training for those professionals provided in the regulations to undertake the functional assessment of capacity for those purposes.
Very good, thanks Elaine. Brendan, sort of a follow-up question just in terms of capacity. What is the process where there are conflicting opinions between the MDT in relation to where an individual has capacity or not?
Well, the Act doesn't specify what's to happen in that circumstance. So I think the best approach is to deal with that conflicting opinion in the same way that we currently deal with conflicting opinion within the multidisciplinary team, which is hugely variable. But I mean, the principle is that no one discipline on the team necessarily has priority or in assessing capacity of the patient, and that, you know, the assessment would, if you like, gravitate toward the person with the greatest familiarity with the patient, the greatest familiarity with the decision and the issues at hand. So conflict resolution would be using the standard methods of conflict resolution, however satisfactory or unsatisfactory they might currently be.
Thanks, Brendan. And Anya, or Bear, I shall go to you on this one then. What happens to an involuntary patient who is deemed to lack capacity? What do you do if there is not someone who knows them well, making it hard to establish what their will and preferences would be?
Yeah, so I suppose it's a really good question, and it's, you know, again, it's, I know I keep harping on about the advanced healthcare directives, but ideally, you know, these are the conversations that we should be having as people are in the services and as the people are coming into your mental health services. So it is important to encourage people to make them. If there isn't someone that they know and trust and support, and apparently I think up to 1/3 of people who are involuntary detained might not have anyone that they can trust. So that's when advocacy and an independent advocacy service and access to advocacy services can come in, and like that they should make as much effort as possible to determine what the person's will and preferences would be. So, and yeah, the decision making, it only comes into a case when someone doesn't have capacity. So again, up to that point, there's conversations around will and preferences, supported decision making, getting to know the person, and it will require a bit of time.
Thanks very much, Bear. And I think at this stage, just looking at the time, I'm going to bring the session to a close. I know there's probably plenty of questions left, and there will be plenty more questions arising over the coming days, weeks and months as we move towards the implementation of the legislation and thereafter as well. So that's the end of our session. I hope you found it helpful. I'd like to thank our speakers, Mary, Brendan, Anya, Bear and Elaine. Also, my sincere thanks to Aisling and Tony in the National Mental Health Office and Tom for putting today's webinar together. Also, sincere thanks to Caoimhe and Jacqueline and Elaine from the National Office for Human Rights and Equality Policy and the Mental Health Operations Working Group for ADM, and Colin Lahan in that group as well. All slides and presentations and questions and answers that have been submitted will be uploaded on HSE Land and assistedDecisionmaking.ie, and a link will also be shared to the recordings and presentations after the event. Thank you all for your attending and for your engagement and your questions throughout. I think it was a very useful session, and I hope you found it helpful as well. I look forward to ongoing engagement as we head towards the implementation and the introduction of the Act. Thank you all. Good afternoon. Bye now.